TV.
Thank you, our viewers, for joining us. I'm Karagaba, Baldwins, and we're coming to you live from the campus in the International Conference Center. It's a beautiful Saturday evening. Uganda Cranes has beaten a very phenomenal team without anyone expecting for that win to happen. However, we have a poignant matter of concern in this nation, and that is the phenomenon of HIV/AIDS, and all of you knowing the history we've had with it. So we want to interrogate the progress made about its elimination or perhaps its reduction. Before we go into the studio discussion, let me have this introduction, then we'll be right back.
Uganda has long basked in the praise of the international community over its swift and progressive response to its crippling HIV and AIDS epidemic. Due to over 30% of Ugandans having contracted HIV in the 1980s and the 1990s, the government created an urgent need for people to know their HIV status. Since then, HIV and AIDS has been approached as more than a health issue. In 1992, a multi-sectoral AIDS control approach was adopted, and the Uganda AIDS Commission, founded in 1992, which has helped develop a national HIV/AIDS policy. To further Uganda's efforts in establishing a comprehensive HIV and AIDS program, in 2000, the Ministry of Health implemented birth practices and safe infant feeding counseling. According to the World Health Organization, around 41,000 women received preventing mother-to-child transmission (PMTCT) services in 2001 alone. Uganda was the first country to open a voluntary counseling and testing VCT clinic in Africa called AIDS Information Center, and pioneered the concept of voluntary HIV testing centers in sub-Saharan Africa. The Ugandan government has promoted this as a success story in the fight against HIV and AIDS, arguing it has been the most successful national response to the pandemic in sub-Saharan Africa. However, there has in recent years been growing criticism that the government is concentrating much more on treatment campaigns rather than prevention of the virus spread. The provision of all health services in Uganda is shared between three groups: the government-staffed and funded medical facilities, private for-profit or self-employed medics including midwives and traditional birth attendants, and NGO or philanthropic medical services. The international health funding and research community, such as the Global Fund for HIV and AIDS, TB and malaria, or bilateral donors, are very active in Uganda. According to UNAIDS, in 2017, an estimated 1.4 million people were still living with HIV by then, and about 26,000 Ugandans died of AIDS-related illnesses. They claim that the epidemic is firmly established in the general population, whereby HIV prevalence among adults aged 15 to 49 stood by then at 5.9%. Women are disproportionately affected, with 8.8% women living with HIV compared to 4.3% of men. On this note, NTV, in conjunction with the Ministry of Health, bring to you this live discussion as we review the recent progress, challenges, and way forward in the fight against HIV and AIDS in Uganda. You are welcome.
Karagaba Baldwins is my name, and as I said, this is a very plangent matter of health concern dealing with disease, death, and trepidation, of course, in the whole nation because of how much calamity that befell this nation with that particular virus. And on social media, we've posted a question showing you that there is a disparity in reports about the very status of the HIV issue in Uganda. Some saying that the threat has reduced, others saying that it has heightened. And we've asked you what your view is. And Kasangachi Rafael says that the Ministry of Health should be responsible for those conflicts because it seems they are applying politics in health, waiting for early 2021 polls. Musoba Ivan says that we thank the government for the effort, but there is a certain percentage that have never taken the will to know their status. I think much effort is needed for community sensitization. And lastly, Moses says that HIV has no cure, but the best thing the health ministry can do is lobby for funds that can be used in research and massive sensitization of our people on dangers of this monster. And on that note, please continue having those responses. I'll keep on citing them as due necessity requires. So let me get into the discussion with my prolific panel of specialists in this very field. And right on my extreme left, I have Dr. Joshua Musinguzi, Assistant Commissioner AIDS Control, Minister of Health. Dr. Joshua, you're welcome.
Good evening, viewers, and thank you very much, Baldwin.
And in the middle, the prominent Dr. Nelson Musoba, who is the Director General, Uganda AIDS Commission. Nelson, you're welcome.
Good evening, viewers, and thank you very much for hosting me.
Very glad to have you. So, Dr. Joshua, let me start with you. The statistics, just as even we've enumerated them here in the introduction, you have 1.3 million people living with HIV, a report done by UNAIDS in 2017. 5.9% adult prevalence, 50,000 new infections, 26,000 AIDS-related infections. And there are certain other researches which give a slight variation on those particular numbers. So me as an interrogator, I ask how true and genuine are these statistics? And isn't there some kind of fabrication or trying to inflate numbers for purposes of keeping this threat above the very fray in which it might not exist?
Thank you very much, Baldwin. And just to give a little bit of context, I just want to remind viewers that we've been having this HIV problem over the last 4 decades. Uganda and many countries have suffered a disproportionate burden of HIV as a disease. And as a country, we have gone through various phases of this epidemic, right from the beginning when we had the earliest cases of infections reported in the southwest of the country, in Rakai in 1982. And over the period, we have had periods when the epidemic shot up in the late 80s and peaked in the 90s at 18%. And then we did have, because of the interventions which were being implemented, and especially because of the leadership of His Excellency the President, we saw HIV prevalence coming down to about 6% at the beginning of the 2000s, this current century. Around that time, we had a bit of stabilization, but slowly then we had a bit of creeping up between 2004 from 6.4% to 7.3%. The last measurement that we did, the Ministry of Health working together with partners, especially the US government through the Centers for Disease Control, was through a big survey that we implemented in 2016, which we call the Uganda Population HIV Impact Assessment Survey. In that survey, we went across the whole country, and we did do a number of things in the community. And as you would know, to go back to the question that you have raised, that data is critical and it's very important for us as a government and as a ministry, and we must always look at having the best quality data. Our approaches to measuring this epidemic has premised on ensuring that we have good protocols that we design. We want to make sure that we have very good data collection tools. We want to make sure that we have resources to be able to collect good quality data, analyze it, and produce the reports that we give you. Now, there are like 4 main sources of our data before I go into the details of the Uganda population HIV infection impact assessment survey. The first one is the routine data that we collect through the health facilities. This is data that comes in on the routine service delivery that takes place in health facilities through what we call the HMIS, the Health Management Information System. Some people like calling it the DHIS system. That's the first source of data. Very good data, very important data, but as you would imagine, it has limitations because it's for those individuals that come to the facilities. The second source of data is that which comes through what we call our annual antenatal surveillance surveys, where we collect samples from across the country and look at these samples and measure them for HIV and produce an estimate within these subpopulations. That's the second source of data. The third source of data is the one I've just been talking about, which is the population-based surveys. These are almost really like the gold standard because you are going out there into the community, you determine a sample size which is strong and good enough to be able to give you a stable estimate of the magnitude and the number of other indicators of HIV and a number of other indicators. Now, we've done these surveys for a long time. The first survey we did at the population level was 1988. The second was one was in 2004, 2005. The third one was 2011. The next one is the one I was talking about, which is the 2016 Uganda Population HIV Impact Assessment Survey. And this survey is a gold standard, well designed. It has a good sample size. It is able to measure for you indicators at the national level, at the regional level, and in some cases even below. And also you are able to disaggregate. And the protocol is well described. The tools are well described, and you select a number of interviewers, train them, and these are really the best that you can have. And you go out and collect this data. So there are no issues around quality because you want to make sure that you quality assure each of the steps that you take in collecting this data.
So in regard to the particular data that has been collected in those efforts, just in a slight response, is HIV, stroke AIDS infection rates increasing or reducing?
We have, as I was indicating earlier, we have been seeing significant improvements in a range of HIV program indicators. The number of new infections which are occurring in the country has significantly come down.
Okay.
As you were saying, in 2013, we were seeing 100,000 new infections occurring annually. At the end of 2018, we only had 53,000 new infections occurring
let's pause on that
annually. And then I also want to add here that we have also seen the number of AIDS-related deaths, the people who are dying as a result of this epidemic, coming down because of a strong program for treatment, coming down from 60,000 annually in 2013 to currently now only 26,000. A number of other indicators have also been significantly in the right direction, moving north, looking at, for example, the coverage for treatment and the coverage for a number of service delivery indicators for both prevention and HIV treatment. And those improvements in those indicators has been matched by the improvement in the impact indicators, which I was talking about, which is the HIV incidence, as well as AIDS-related death. But there's also another marker of impact, which is the viral load suppression, which measures the level of virus in HIV-infected population, which actually is a measure of how good the treatment program is happening, and that has an impact on HIV incidence or the number of cases.
Absolutely, we're coming to that in terms of the aspirations being drafted, which were crafted in the 2030 agenda and the 2040, making sure that there's an elimination of instances. Dr. Nelson,
yes.
So let's talk about financing, because definitely there is an implication on how you fight this war and win it, and the Ministry of Health, of which Dr. Joshua is prominently involved, has been allocated 2.5 trillion. However, when I look at the amount of money that has been allocated to you for your commission, AIDS Commission, is about just 6.7 billion, okay, out of 2.5 trillion. Quite a significant drop, a droplet in the whole budget allocation. So just talk about the financing system in this country and how the commission, because there's a subsequent question which is going to come, and I'll tell you why this question is relevant. what is the financing system?
Now, in terms of financing,
and what determines the allocation of just the 6.7 billion? I would expect that you get something far more,
yes,
much bigger than that.
In terms of financing, at the beginning of the implementation period, and that the period I'm referring to is 2014-15 to 2019-2020, you know, the corresponding to the NDP2. We developed the National Strategic Plan, and in the National Strategic Plan, we agreed to the priorities, that what are the priorities for HIV/AIDS for us to be able to implement in this period to lead to the results that Dr. Musinguzi has been talking about. And within those priorities, you have HIV prevention, you have care and treatment, you have social support, you know, responding to the impact of those who have been affected by HIV/AIDS, and also health systems. So within the health systems is where you have the coordination component, you know, bringing together the multi-sectoral players, ensuring that the different components are doing what they are supposed to do. So within the strategic plan, we estimated the needs for responding to the HIV response per year for that period. And the average for expenditure is between $600 million to up to $900 million. That is if you had 100% of the package. Now within the coordination component, as Uganda AIDS Commission, we also have a strategic plan. And our estimated requirement on expenditure per year is about 20 billion Uganda shillings as need. And we've been interacting with Parliament and the Minister of Finance, you know, asking for the budget for Uganda AIDS Commission to be raised from the current figure that you've talked about to, you know, closer to what the actual need for the commission would be. And indeed, this financial year, we have some good news to report, which we only received after, you know, because when the budget goes to Parliament, there are final decisions that are made, instructions are sent to the Minister of Finance, and we've received an additional 2 billion shillings. So our actual budget,
about 9.7.
Yeah, our actual budget is slightly higher than that.
Less than
Still,
half of what
yeah,
you need.
still much lower than, you know, what you would require to coordinate the response. We are still, you know, trying to articulate this. We'll go back to Parliament, thank them for that decision, but say that we still need much more to focus on aspects like communication, you know, what we are talking about, assuring that the right information goes to the target groups, that the young people, because one of the groups that we are focusing on currently are young people, what we call the millennials, who were not there at the time that HIV was very evident.
Yes.
And we really need to focus. When you talk about HIV, it's like a story.
Yes, it's a strange aspect.
Yeah, it's a strange aspect. So we really need to have to intensify the messaging.
The challenge with that particular, because the breakdown of that budget that I saw, prominently, the big chunk of it is like actually about 90%, is going to wages and non-wage, the recurrent budget, which is 6.7 billion going to wages. And so somebody asked, and just the development budget is about 127 million. So it sounds like the budget is there just to sustain the people who are employed in the commission, and perhaps it's no longer relevant. So how do you do all these other things with this just funding majorly committed to employees?
We receive an additional amount of money also from the partners, our development partners. The Irish government is providing $400,000 every year to again support the activities that we do around the coordination of the response.
So the money is not reflected in this budget, the one which comes from international
because
development
what you're
partners.
seeing is government of Uganda contribution, but the partners are also contributing to some of the activities. So it shouldn't appear as if, you know, we are paying salaries and people just sitting in the offices.
Exactly, that's how it appears in this budget allocation. All right, and Dr. Musinguzi, just about 2 minutes, because I need to take a break after this introduction. But let's talk about the strategic methods and the principles that are being used. Because in the commission itself has these different objectives to strengthen governance, leadership, and management systems, to mobilize adequate resources for the national HIV and AIDS response. And there are about 4 objectives. So just assist us to understand the principles and the methods you use in the combat against this particular scourge.
Thank you very much, Baldwin. In addressing a disease problem, as big as HIV and AIDS and any other disease. There are principles that you need to follow as a public health specialist. In the Ministry of Health, we spearhead the public health response to the HIV epidemic. The most important thing that we want to start from is to make sure you have a right policy and guidelines that you are going to use to implement your response. There are those that are global, and then there are those which are specific to the disease that you are addressing. For instance, it's very important, for example, like in Uganda, the political commitment that the government has put in place for people to be able to come together, the Ministry of Health together and other partners, to be able to implement our programs. In some places, they have lacked political commitment. The issues around openness, the issues around the multi-sector approach to ensure that we have all sectors in place. But going back to the Ministry of Health, we are implementing part of what we call the combination HIV prevention interventions. There are three main areas that we focus on in combination HIV prevention approaches for Uganda. The first one is the structural interventions. And those are interventions which are at the level of the community, the barriers to access to services at the community level, and sometimes the cultural and social factors that predispose to HIV infection in the population. The issues of gender equality, the issues of poverty, the issues of some of the backward cultural practices that we have in this country, like widow inheritance and so on, the issues around early marriages, those are being addressed, probably not in the Ministry of Health, but by other sectors, as you'll hear from Nelson.
Yeah. So just
the second area...
Just a second.
Yeah.
You're going to help me enumerate those other two. Then I need to go for a break because of the structuring of the program. Yeah. We'll come back, and because you noted on something about poverty, the nexus between HIV and AIDS, you also deal with that. Let's go for a break and then we'll come back. Thanks our viewers. Just let's go for a break and come back and continue in this very fascinating but poignant matter. I'm Karagaba Baldwins once again, and this is NTV, your #1 station, and we are having a retrospective and current interrogation of the study, rather of the status of HIV/AIDS in Uganda. And on Facebook and Twitter, we've posted another question asking you about your view on the aspiration that is, of course, orchestrated by the UNAIDS, United Nations AIDS Commission, asking Uganda, which is, of course, a signatory to that commission, to have the cessation, like to stop AIDS infections by 2030 altogether.
Ending AIDS.
Actually, ending AIDS. I think HIV infection, because you're going to get the argument against that if somebody is infected by today, within 2030, he will still be alive. And I can see Aero Elin says, I think their actions should speak louder than their words. Mbara Regional Referral Hospital, especially the ISS clinic, is working so well towards that goal. Okay. Anil Madut says that this is very possible to Ugandans if they improve ANC, PSC. Okay, doctors, you're going to have to explain that perhaps. And Ali VCT, besides FP methods, they can achieve this together with other strategies set up. And lastly, Utman, he says, impossible as long as this government is still in place. I should not be laughing about that, but that is his own opinion, Utman Karunji. A very huge skepticism that as long as people in power are still there, you're not going to have that goal arrived at. Dr. Joshua, so you have a paper study, research titled Poverty and HIV/AIDS Impact Coping and Mitigation Policy by Tony Barnett and Alan Whiteside. They make this conclusion about the nexus between poverty and AIDS, and says that AIDS deepens poverty and increases inequalities at every level: household, community, regional, and several sectoral areas. Just, of course, you're going to help recap back on those two methods we were talking about, but also talk about the nexus about poverty and HIV, and how can this nexus be broken? Can somebody be HIV affected or infected and they live a prosperous life?
Yeah, let me just, some of that will be taken by Nelson. Let me just conclude what I was saying before the break, that the three main areas, mainstay for our implementation of the combination HIV prevention. First one was the structure that I talked about. The second one is the behavior. The behavior, ABC, as you know, abstinence, be faithful, and if not, use condoms. And we segment our population to make sure that we are age appropriate in delivering that package. But we also have what we call the biomedical interventions, very significant biomedical interventions, which include, again, condom programming. These are the ones which are really more of the biological approaches, making sure that we treat we detect and treat STIs early. STIs are sexually transmitted infections, making sure that we provide programs for elimination of mother-to-child transmission programs, making sure that we provide voluntary medical male circumcision, and making sure that we provide antiretroviral treatment, because we know antiretroviral treatment is critical not just for the outcome of the individual, but also in contributing towards prevention. And all these three are based on evidence, evidence-based. As you know, the main risk factors, modifiable risk factors for HIV transmission in this country is multiple concurrent sexual partnerships, where individuals are having unprotected sex with many partners. The non-use of condoms is another very important risk factor. Non-circumcision has been also shown to be a critical risk factor. We also know that a high mean viral load in HIV-infected population contributes to HIV transmission. So those are the key things that we're focusing on around evidence, and we are implementing our interventions to scale to ensure we reach every gender, every geographical area, everybody not left behind, for old people, young people, and populations which we call the key populations, which include groups like sex workers and other individuals that are sometimes left behind. So that package of interventions to scale and to fidelity will help us bring down HIV infection and reduce AIDS-related death. Now, to go back to the issues around the structural intervention, maybe Nelson will add in here. It is critical that we look at the factors that drive the epidemic in the community. These are mainly the structural interventions I was talking about. You know, in our communities, many times there are issues around poverty that contribute to individuals not having opportunity to access services, to access education, to access healthcare, and to be able to have a voice and a decision-making power in making their decisions. Those are very, very important areas for us to be able to address. It is not that poverty will make you acquire HIV, but the factors around poverty,
make you more vulnerable.
They will make you vulnerable in terms of the decisions that you're going to make. You've heard of many of our young people who have been unable to continue in schools because they cannot afford to continue in schools. Luckily enough, that is reducing because of our policies around the universal primary education and universal secondary education. They may be highly predisposed to getting infected because they engage in risky sexual relationships for small things like tokens of money, for small things like sometimes a meal, a handout of a meal, and things like that. So there is going to be a need for us to empower the population in terms of opportunities, in terms of education, in terms of jobs, in terms of creating opportunities for people to be able to remain, not being left behind. Okay. This is in addition, of course, to government coming in with all these interventions which have come in that we're talking about with policies of education. We are working with the Ministry of Education now and some of our partners to focus on adolescent girls and young women, because these are the ones who are most vulnerable to these kinds of pressures around poverty, gender imbalances, and falling out of schools and early marriages that actually are key drivers in acquiring HIV infection.
Okay, great. Definitely, the flip of the question was about someone who has contracted HIV or affected. Do they become, is it a death sentence, a sentence over them that they're going to die poor? But because I need, on this, I need Perhaps you can comment on that.
Yes, it's
and then you help the president set up an agenda 2030, which I've already asked as a question for the public to respond on. And during that time, when it was being launched, he issued a handbook and he spelled out plans to tackle this HIV. And I think he engages a whole lot of systems and parallel approaches to ensure that this is achieved. 2030 infection-free HIV status. He says that we need to accelerate implementation of test and treat and attainment of a 1990 targets. And then you have to consolidate progress or eliminate mother-to-child transmission of HIV. And so there's that component of 1990 targets. At times some people do not understand where it is coming from, and definitely it is an ambitious treatment target to ensure that you have various issues dealt with, that of all 90% of all people living with HIV are diagnosed, and then you have antiretroviral therapy treatment for 90% of those people. And I'm just trying to make sure I clear out that. But that ambition, is it achievable as you also deal with how do you palliate the situation of someone who has contracted HIV? Is it a sentence for them to die poor?
No. Contracting HIV is no longer a death sentence. It was, a while ago, at the time that, HIV was first detected in this country. We largely focused on prevention as the mainstay, Treatment was inaccessible, it was very expensive. But in the early 2000s, treatment started to come in, and the government has come in together with partners and made sure that this is largely accessible free of charge. There is still a cost probably to travel to the facility to be able to access that. And the science has shown, and even the results that we see now, have shown that once you take your treatment consistently, you're able to reduce your viral load, you become healthy, you're productive, you go about your business, and therefore you are able to break that poverty chain and become. But the other factor about treatment is that once your viral load is undetectable, you don't pass on the infection to your partner. So it's prevention. Treatment is also serving as prevention, which is very important. But you're able to break the chain of poverty, and you become as productive. We have so many productive individuals in our own community who are living with HIV. You wouldn't know, they even look more healthy than the ones who are HIV negative. But that is not to say, in fact, for young people, we tell them that there is still no cure, and therefore taking lifelong treatment, there are side effects. It's not, an easy thing, and therefore prevention remains our primary mainstay. One should aim to remain HIV negative as much as possible.
Antiretroviral treatment has side effects?
Well, like any medication. Any medication, first of all, you must take it daily. You need to have meals, eat well when you're taking it. And like all medications, they vary from person to person, but yes, indeed, they have side effects.
Okay.
Yeah.
Dr. Joshua, so you have, according to the 2018 Global Corruption Barometer.
Before you go, I just want to just say,
yes,
just add on to what Nelson was saying. The 90 targets are very important.
Yeah.
And
which are being enumerated on the screen.
We are working round the clock to make sure that we achieve those targets. We have two main goals. The first one is epidemic control by the end of 2020. And those are 1999 targets are aiming at that. But the 1990 targets also go with other very important interventions within our fast-track interventions for ending AIDS. And as I indicated to you, the key aspects of condom programming, the aspects of voluntary medical male circumcision, the aspects of prevention of mother-to-child transmission, ensuring that that package is scaled up and made available to everybody. It's going to be very, very important.
Okay. So the challenge now is on how people who are affected and infected by this particular scourge, the treatment is supposed to go to them. Is it really going to them?
Going to them.
Because there's issues of corruption, and of course recently a colleague of mine called Solomon Sebanja was making a very frightening discovery about the racket that is going on systematically. But of course that is about malaria. However, it is implicative of the sickness of the system. And according to the 2018 Global Corruption Barometer, somehow you have a good indicated that bribery has reduced in there, but because the people who are working in the health system are not being qualitatively facilitated or paid, it is making this particular endeavor to have people treated properly very difficult.
Yeah.
So corruption in the ministry, how safe are we?
So I wanted to just finish the point about treatment. Treatment is reaching the people. As we speak now, on our journey towards the 90-90-90, Uganda have revised our targets actually to above the targets that UNAIDS have set. We are now looking at implementing 95, 95. Because we have actually reached the 90s in some of the subpopulations. Where we are
So
now, we are close. We are now at 89% in the first 90. 89% in the second 90, and about 90% in the third 90.
Just that 90-90, because it needs to be simplified. You're talking about making sure there is diagnosis,
so 90
there is treatment.
89% of the population that are living with HIV have been diagnosed.
Exactly.
And 89% of them have been put on treatment. And 90% are viral suppressed.
Yes.
And this is overall. But when you look at, for example, subpopulations, like among women, we have already achieved the 90% among women. We are still lagging behind among men. These are us, the men, are the problem now. The men are not coming for testing.
Yes.
The men are not coming for treatment, and that's where our focus is on now. And then secondly, the young people, the adolescents.
Yes.
The younger people are also not coming into testing. They are also now not coming into yet as the proportions that are in treatment are not yet where we want them to be. So that's where our main focus is going to be.
Corruption.
Now, with regard to commodities, if you hear now, I don't think you have heard anything, Baldwin, about any stock out of ARVs. There's a time about 3 years ago when you would have a lot of challenges. But now, we have worked with our partners, the Global Fund, the US government through PEPFAR, which includes Centers for Disease Control, United States Agency for International Development, and the Department of Defense, and also the government of Uganda contribution. In this coming financial year, the government of Uganda has added on to the amount of money that was being put into the treatment portfolio for Uganda. Previously, it was only about $26 million. They have added on another $13 million, bringing it to about $40 million US. So the issues around commodity security, both for HIV testing kits and the drugs, and even for other prevention commodities like condoms, is now history. That one, I don't think you have heard about it anywhere else. Now, the unfortunate this point that you raised
about corruption,
about the
drugs being stolen,
you saw the commitment from the Ministry
yes.
of Health, and you heard from
and I'm actually not specifically referring, I'm just giving you a sample extract of what is happening in the that it's likely that actually also HIV drugs might be stolen, or the money they're supposed to purchase them.
Yes, and you had the commitment from the Minister and the PS, that the Ministry of Health and the leadership of the Ministry of Health, the government, are going to focus on ensuring that these leakages which have been taking place, in this case for the malaria drugs that you saw, are breached.
Yes.
Because this is something which is completely unacceptable.
Okay.
It is something that should not really be happening. We are getting our partners to support our programs. The government is putting in investments to support our programs. We must put in place mechanisms. And already that has begun. You heard about the softwares that have already been put on the national medical stores, which are going to increasingly go down to the level of the facilities and to strengthen the governance systems around the facilities and the districts to ensure that really commodity security is ensured.
Yes.
We have not had this around our HIV commodities, and we hope it is not happening.
Yeah, I've actually also tried to do much digging, but I didn't.
But I can say something small about that also.
Yes,
that
and
one
conclusively in that regard, because we did not address this. The ambition for 2030 is that you avoid, there is literally going to be a wipeout of infections. Then by 2040, HIV will be totally cleaned out of this country. But based on the political, social, and economic hurdles that this nation faces, skepticism is very high.
No, we've now just on the issue of corruption and health workers. I think health workers are among those who have benefited from the salary enhancements, being in the category of scientists, and also the DHOs who had been previously left behind. I think this financial year their issue was addressed. But we also call on communities to continue, like the issue of where the media moved in and was able to expose that. I think if communities step in, if they ask questions, if they are on the lookout, it will help to ensure the security of commodities even more, so that the little that goes there is utilized for what it's supposed to do. Coming back to the targets for ending AIDS by 2030, it's possible. We've come a long way. Like we said, when we started, the medicines were not even available. When they came, the pill burden was huge. Somebody will swallow up to 20 tablets a day. We've come down to where someone is swallowing a single pill once a day. Research is going on, research for both vaccines, but also for a cure. So we are optimistic, even with, first of all, even without a cure, we know from the projections that by 2030, we should reduce the number of new infections to a basic minimum, to zero.
Yes.
The number, no one should die from AIDS-related deaths, and because we are speaking about it day in, day out, discrimination should also be zero. So that's what the people will have infections, they will be HIV positive, but they will not have AIDS. They will not be sick, they will not be lying in their beds, and will have broken the chain, because if they are virally suppressed, they will not be passing it on to the next partner. So that's what is defined in public health as ending AIDS by 2030.
Okay, great. So far, a phenomenal way of giving hope to this nation about this particular scourge. So let me go for a break, come back, and we conclude this. Thanks, our viewers. Please, let's go for a break, and we come and we just summarize up this. That you are keeping with us this late evening. I'm Karagaba, Baldwins, and we are talking about the status of HIV/AIDS in Uganda. And let me revert back to the first question we posted about your thinking, rather actually the second question, about the targets which have been set for the stopping of HIV/AIDS infections by 2030 in Uganda, and whether that is viable. Albert L.A. says that how is it possible? Are they going to kill all patients? What I know, a person can live with HIV for over 35 years, so if one got it today, by 2030, no, we're talking about infections, new infections. Manzi, Kevin says, depends on the strategies going to be used. And lastly, Mugume says that first it was HIV-free generation, and that has failed now, that it won't work. Just want to eat money from those who are funding. Doctors, you're hearing the response. So, Dr. Nelson,
yes.
How do you help these people who have been infected? How are you helping? Let me phrase it that way, because I guess there's work being done. And the Ministry of Health, in which Dr. Joshua is very embedded, in 2016 says that around 1,730 health facilities in operation in Uganda were offering ART and retroviral.
Now 1,900.
Okay, implying it has improved. And in the same year, nearly 898,000, about 900,000 people living with HIV were enrolled on that treatment.
Now 1.2 million.
Okay, I couldn't get that information, but the good thing it's a positive progression in that regard. So how are you helping the people who already are affected?
The first step is actually for somebody to go and know their status, because with the current strategy of test and treat, once you test HIV positive, you're started on treatment, because starting on treatment is the first help, because we would like to break the transmission cycle. So with the 1.2 million people who are on treatment now, out of the estimated 1.3 million, it means there's another 100,000, about 150,000 who are out there. They're HIV positive. Some of them do not necessarily know that they are, and the only way they will know is to go and test, know their status. So start on treatment. If you have other opportunistic infections, they will be treated. If you have tuberculosis, it will be treated. The expertise is there. The medication is available. And then there is also social support, for other categories, for orphans, related to those who have lost either the heads of households. They support through either the Ministry of Gender or Education, because school is one of the spaces where we think Once children are kept longer there, they are safer. And there are a number of programs, either, accessed through Ministry of Gender, through our partners. We have, the partners supporting a program called Dreams in a number of districts. So different categories of the population have, programs targeting them to ensure that they benefit from this support. And for those who are positive, getting on treatment, being, living and getting back to their normal livelihoods. Those who are supposed to be in school, they go back to school and continue with their studies.
Okay, an optimistic picture in that regard. Dr. Joshua, your last take on this. So, the aspect of behaviorism and the influences of modern culture, where there is free living, free sex, okay, like group sex, all this. Let me just be that blatant. You have prostitution, you have pornography proliferated all over, and of course you have a report which was done, still the one I've been referring to by UNAIDS, indicating that HIV prevalence is almost 4 times higher among young women aged between 15 to 24 years. And HIV prevalence among sex workers at 37%. And that is frightening. It's a behavioral aspect. How do you deal with the behavioral, cultural, and social misdemeanors or perhaps mischief that goes on, that proliferates this whole problem?
I think those are really challenges of the new world in terms of the young people and their access to the new cultures and the new what they are. I don't know what to call them, but that's a challenge for us as a whole, really, because many of those things are a product of the society that we are living in. We need to go back to basics in some of those issues. We need to go back to the family, to strengthen the family. For parents to be parents, because we are having problems of absent parents in some situations where children are left to be minded by television, to be minded by social media, to be minded by maids. We also need to go back to the schools and work with the schools to make sure that we really go back to the basics of teaching the right messages around. We have a sexuality education framework which defines most of those packages that aim at keeping our young people free from HIV. And also we have got to go to work with the different leaders in this community, the religious leaders, the cultural leaders, the political leaders, to go back to see how some of those things can be addressed. But also there are opportunities, because through some of these modern communication methods, especially social media, we can also reach the young people with messages. We are now working with the different stakeholders, like CHC, which is Communication for Health Communities, to start working with these platforms, so that we put messages and the hashtags of this world, so that we can begin to reach the young people whom we cannot reach through the conventional means like this one, like the radio, like interpersonal communication. But you can always find in WhatsApp, you can find in Instagram, you can find through all these different channels. So as we grapple with addressing some of those cultural shocks that we are seeing, we also want to make sure that we take opportunity of the opportunities that some of those new methods are providing to being able to reach, because we want to reach each and every individual. And especially the young people who are just coming through, we must make sure that we reach them with messages through homes, parents, teachers, but also through these platforms. Yeah.
Okay, great. The other in addition, to the religious leaders, cultural leaders, and households, the other strategy we are using to reach young people is young people themselves. Because young people know the language, peer-to-peer approach, they know how to communicate. So recently, during the Candlelight Memorial, what we did, for instance, as Uganda AIDS Commission, was take on one of the groups of young people called UNIPA, and we just told them this is what we like to do. They are the ones who arranged everything, and it was very colorful. The reach was quite wide. So working through young people themselves, empowering them, and they take this message outside, as long as it's the correct message, it will be very impactful. So it's one of the strategies that we are using.
So just as we wrapping up, just 2 minutes. Of course, the most prominent and memorable campaign phrase that we had, which you alluded to earlier on in the fight against HIV, was ABC, abstinent, be faithful, which is monogamy, and making sure you're faithful to your partner, and condoms, of course, to a Christian community, it is Christ. What is the new message? Is it, are we still continuing with this same approach in terms of communication? And what should be the involvement of the public in this particular fight? Just 2 minutes and him.
The public, first of all, every individual should take it as their own responsibility to protect, one, themselves, and also either their partner or their offspring. So that individual responsibility is key. But that message still remains that Dr. Musinguzi said, it is HIV combination prevention. If you're still, not yet an adult, you've not yet started sex, don't have sex until you're ready for the consequences, until you're old enough. If you're in a partnership with somebody, be faithful to your partner. Don't have multiple concurrent partnerships. And if one of you is HIV, if you're a discordant couple or there are risks, then you have to use a condom. So that old message is really stays, plus treatment. So
to those who are infected.
Yeah, to those who are infected. So having a combination of the two is very important, and it's what will lead us to achieve the targets that we've set.
Great. Yes, Doctor.
Yeah, just in closing, first of all, I want to react what Nelson has indicated. Secondly, I also want to call upon the public to utilize the services, because the services are there. Now we have gone into a stage of to kwega people now to make sure that they utilize the services, as opposed to the previous period when we would have stockouts. Now we are finding challenges with people not coming back to take their medications, not adhering to their treatments, and that is a big problem. So we call upon the public to utilize the services, both in the facilities but also in the outreaches as we are coming to them. But also I want to thank the partners that are supporting the programs, the government of Uganda's leadership, the partners from the US government through PEPFAR, CDC, USAID, Department of Defense, and the Global Fund, as well as the UN family, WHO, UNAIDS, UNICEF, UNFPA, UNDP. They have done a good job in providing the resources, both financial resources but also technical resources that have helped us to put in place a capacity that we're now able to provide packages of interventions that the public will need. What we need the public to do is to come and utilize these services. Those who are on treatment, make sure you take your medications. It's just one tablet like this, and there shouldn't be a problem. Those for prevention, make sure you maintain your ABC. And there is individual responsibility as a person, responsibility as a family, responsibility as a community, but also responsibility as a nation.
Just something slight about stigma that we didn't address. And do you still find that stigma is still an issue, or people have come to terms with the fact that this is a disease that is a challenge to?
Interestingly, even after more than 30 years of having HIV and AIDS in the country, there's still stigma. There's stigma in the communities, there's stigma in schools. The children who are HIV positive and on treatment are defaulting on their treatment because they have to take it in hiding. So again, we have a program with the Ministry of Education. We want to go out, first of all, to stigma is largely due to lack of information. When people don't know how, a given, because they are not sure about how the disease is transmitted, even with all this information, they think that, by sitting near somebody or shaking their hands, they may get infected. So arming them with information is what will break the stigma.
Okay.
And that's what
and on that note, gentlemen, have been profoundly excellent in helping to restore hope about this particular threat. And Dr. Joshua Musinguzi, the Assistant Commissioner AIDS Control, Minister of Health, and Dr. Nelson Musoba, Director General, Uganda AIDS Commission, we are very grateful for giving your time to share the progress on this fight.
Thank you for hosting us.
Yes, and Dr. Joshua, say hello to the Minister, and we're grateful for choosing us as a platform.
Thank you very much.
Indeed. Thanks, our viewers, for keeping us logged on to your set as your #1 station. And if you're there as a ministry or a department or an agency or a corporate organization or an NGO, and you want to have a properly structured discussion that deals with phenomenon that is national, but is contextually guided by your input, please come talk to our general manager, myself, and the sales team, and we'll have that done. Otherwise, thanks to the Ministry of Health, and thanks to you, our viewers, for contributing on social media platforms and for watching. God bless. Good night.